Thank you for this opportunity for sharing my thoughts. I'm going to be talking sort of very generally to give a context of where AI should be heading towards. And I want to frame it in the context of universal eye health. Because as far back as 1978, there was a declaration made that there will be health for all by the year 2000 in alma mater. So that year went by, and all of us know that we still don't have health for all. And today we're talking of universal health. And I'm not sure we're put in a timeline based on the past experience. But I see a lot of hope that this can happen. So this is the context of my short presentation. This, I think, has been spoken by many of the earlier speakers, that we quite often, arrive at solutions and really not knowing how to use it. And not completely wasted effort, because sometimes they come handy later on when problems pop up. And then we also tend to be largely working on problems for which we know how to work on. It may sound like a paradox, because we get so many requests in the hospital for working on images, because everyone knows how to work on images. Now, so I think we need to kind of change that paradigm a little bit. And I'm kind of offering this framework to think about. Because in pretty much in everything that we do, this equation exists. There is this equation of demand versus supply. And I think if you can work on both, then you have a relevant and a successful solution. On the demand side, again, I want to kind of contextualize it to developing countries, where those who are not getting care far outstrip those who are getting care. Sometimes by a factor of 3 or 4 times. So added to that, as we are going into chronic conditions like glaucoma, DR, we're also faced with the challenge of retention. Because all of us know that those who are working in DR and glaucoma know that how rapidly they lose patients to follow-up. Our data shows that in year 5, glaucoma outpatient follow-up is at 15% or something like that. Ridiculously low when we know that the risk increases with the passage of time. So if you look at the demand side, to me the 2 big elephants in the room are access and affordability. Okay, and in developing countries, like I mentioned, probably 15, 20, 30% of those who have a problem are into the system. And the reasons could be very many. The reasons could be starting from awareness. But even those who have the awareness are not able to access the system. So can technology, like AI, mitigate this? Can it? And we also have now evidence, like for instance, when we do outreach, many people who don't come to the hospital come in. So that's one solution. But we know it's not adequate. So when we had more permanent facilities, sort of replicating an eye camp to be available 6 days a week, we find a much larger uptake, and our data shows maybe in 3 or 4 years' time you reach everyone who's in need of eye care. Sort of universal access at least. So I think what we're learning from that is if you can take care closer to the people, the access seems to become much better. So can technology help us make that leap in a much more scaled fashion? And similarly, affordability, and it's also very tightly linked to access. Because I think in affordability, we very often tend to focus on cost of care as the main driver, but I would like to expand that, because quite often the cost of getting the care becomes a lot more expensive. If it comes to like glasses and things like that. So we have to look at affordability in a much different way. And I think some of the current solutions like AI for DR grading, once it matures and becomes a regular service, I can visualize that we can significantly reduce the challenges in access and cost if you can offer that not only screening but hopefully also disease monitoring. That is trying to also pick up a change over time scale. So that you can say that this patient is stable, doesn't need to go and see a retina specialist, can see the patient again after a year or whatever time period. So those kind of technologies can actually, and if it can happen closer to the patient's home, they can very, very significantly reduce the challenge on the demand side. It can not only bring more people into the loop, but also retain people within the system. The other one on the supply side, both on the demand and supply side, what I'm sharing is not exhaustive, but just to get that thought process going. On the supply side, I think the big challenges are around efficiency, quality, and then I use the word managing exceptions, because as the volumes go up, you really don't know how to manage what is working well. So you want to be figuring out how to manage what is not working well. And so with efficiency, one can take a much broader view of eliminating waste, enhancing flow, and so on. Just as an example, we have this network of vision centers, and as an internal protocol, we said every patient must get a telemedicine consultation, largely because to ensure that the quality of care is not compromised. And we know fully well, not all patients will benefit from a consultation from a doctor. Sometimes a very simple patient coming for a follow-up visit, but then what we don't know ahead of time is which patients don't require consultation. Okay. So today we end up in a year consulting for about close to 700,000 patients. That takes a lot of doctors' time on the hospital end to provide this consultation. Probably we are allocating 20 to 30 doctors each day just to provide these consultations. While in reality, if AI can help us to predict and say, you only need to have this consultation only for this many patients, I feel that workload can come down by 70 or 80%. So not doing it to me is a form of waste, because the doctor is not adding value by giving the consultation. So if we can start thinking of efficiency from those perspectives, I think we can kind of move towards solutions. And when it comes to expectation, managing exceptions, it will be really nice if at the point of caregiving, that extra knowledge pops up to the caregiver, saying that, oh, this guy in front of me is not likely to follow up. So because today, not having that knowledge, not having the predictive knowledge, we tend to treat everyone as the same. And normally, if it is a busy clinic, everyone gets very little of the same. We're not giving it adequately. But then if one has extra information around outcomes or around compliance and those kind of behavioral or clinical outcomes, I feel that we can kind of do a better job of improving the outcomes to them. So from that perspective, can we look at exceptions, not only on the clinical side, but also on the management side? And similarly, thinking about quality, in any caregiving setting, there's bound to be variations in competency. You have first-year residents, second-year residents, early doctors, very experienced people. But then when you subject a patient through them, you can also recognize that there's going to be a big variation in what the patient actually ends up with in terms of quality of diagnosis or the treatment plan. So that is, I think, inevitable. And I think that we have been living with it because that's the reality. So given that, and then now, since most of the medical information is becoming digital, with EMR, can we look at can start thinking about, can we build AI systems which can minimize these competency gaps, in real time. So as a junior person, a learner who is dealing with a patient, can they get some assistance or help, to direct them on the diagnostic or treatment plan process, which can both help the patient and also be educative for the individual. So these are some of my very broad thoughts on how AI can start kind of making much more significant impact. Because these are real problems that are there in the caregiving process. Thank you.